Right. So if you have read and understood, considering the clinical examination station, can you begin?
I'll enter the room, I'll wash my hands, and
Yes.
I'll introduce myself. Hello, I'm Dr. Karma, one of the exam candidates. May I confirm your name and age, please?
Yes, I'm Samantha, 62 years old.
Hello, Samantha. Nice to meet you. So today I've been asked to examine your neck, which will involve looking, feeling, and also tapping on your chest and also listening. And I'll also examine your hands and legs. Is it okay with you?
Yes.
Okay. So I'll begin by inspection. I'll ask
exposure.
Sorry, exposure. Yes, I will ask to expose her. I'll remove upper one or two buttons of her shirt and then expose her neck.
Yes.
Yes, unbutton. And now I'm going to inspect. I'll ask her to take a few sips of water for me. Can you take few sips of water for me, please?
Yes.
Now, can you swallow for me, please? I'll see whether the swelling moves with swelling move with swelling.
Yes. Yes.
And I'll also ask her to stick her tongue out and see if it moves with the tongue protrusion.
Yes.
Now I'll inspect the site of the swelling, size of the swelling, shape, overlying skin, any scar mark, and I'll also inspect any engorged neck veins. Now, Samantha, I will need to examine you from your back. I'll go at her back, on her back, and then I'll ask her, do you have any pain at the moment?
No.
No, okay. So I'll start by feeling the temperature, compare on the swelling and the other part of the neck with the dorsum of my hand. Then I'll feel the tenderness when I press and see for tenderness. I look at a face to see any grimace. Then I'll feel the edge. I'll feel the surface. I'll see whether the swelling is attached to the skin or the underlying structure. For that, I'll ask her to press her chin against my hand and see whether it's attached to the sternocleidomastoid muscle. Then I'll see whether the swelling is reducible or compressible by pressing. Then I'll also see whether the swelling is pulsatile or not. And after that, I'll ask her, I'll also feel whether I can get below the swelling. And then now, Samantha, can you turn your neck backward for me, please? I'll check for exophthalmos. Now, Samantha, I'm going to come in front again. Now I'll check your windpipe. I'll feel the trachea, whether it's central or not. Then now I'm going to feel your carotid pulse on both the sides. And then I'm going to tap on your chest, upper part of your chest. If you have any pain, do let me know. Then I'll tap to see whether there's retroesternal extension of the thyroid. Then now Samantha, I'm going to listen on your swelling. I place the stethoscope, to listen for any bruit or not. Now, Samantha, I need to examine your eyes. Can you keep your head still for me, please? And then follow my fingers. I'll just sit in front of her, and then I'll keep my fingers horizontal, and then ask her to follow my fingers, see whether there's any lead lag. Now I need you to follow my finger. I'll do the check for eye movement and ask her if she has any, to let me know if she has any double vision. Make a H-shaped movement. Now, I'll have to examine your hands. I'll see for tremor. Ask her to stretch her hands in front and then close her eyes. I'll place a paper on the hands and then see for tremor. Now I'm going to check your pulse. I'll check the radial pulse on both the sides. Now, Samantha, I'll tap on your elbow. I'll see for biceps reflex. Now, Samantha, I'll have to examine your leg. I'll go to the leg. Can you please expose your leg for me? I'll see for any pretable myxedema. Now, Samantha, like I tapped your elbow, I'll tap on your knees. I'll check for knee reflex. Now, then I'll go for check for proximal myopathy. I'll ask her to cross her arms across her chest, and then I'll ask her to stand up from the sitting squatting position, check for proximal myopathy. Yes, so I've completed my examination, Samantha. You can button your shirts, and thank you for your time.
Are you sure?
So I've examined.
You haven't missed anything?
Yes, I missed the cervical lymphadenopathy.
Yes, and?
The cervical lymphadenopathy.
When you were examining hand, you had to check the radial pulse as well?
Yes, radial pulse I checked, ma'am.
Okay, I'm sorry. Ask the patient to cross the arms, stand up and cross the arms.
Yes, ma'am, done.
And while you were checking again, did you ask the patient to drink, swallow again the water? Okay, can you present, yes, your case now?
I've examined Samantha, 62 years old lady who came with a swelling on her neck. The swelling is on the anterior aspect of the neck with 5 to 7 centimeter in size. Its shape is butterfly in shape. There's no overlying scar mark, no engorged veins. On palpation, there was the swelling was not tender. The surface was nodular. The edges were well defined. The swelling was mobile. No, it was not versatile, not compressible, not reducible. The overlying skin condition was normal. It was not fixed with the overlying skin or the underlying structure. I could feel below the gland. On percussion, the percussion note was resonant, which excludes retroesternal extension. There was no audible bruit over the swelling. The trachea was central, and the carotid pulses were palpable bilateral equally.
Yes.
And
so what are your differential diagnosis?
And the thyroid, that she had euthyroid status. My provisional diagnosis will be simple multinodular goiter. I'll also consider toxic nodular goiter, and also consider infection and thyroid malignancy for investigation.
Yes. How would you manage this patient?
For management, I'll do a triple assessment.
Very good.
I need to take a history examination.
Yes.
Then I'll do an imaging of ultrasound of the neck.
Yes.
And then I'll go for FNAC or biopsy.
Yes.
And also do the thyroid function test.
All right. What would be the next step in the management of this patient once you have done the histological result and it shows you? How would you go ahead?
It will depend on the findings, ma'am. If it is if there's any findings of malignancy, then I'll need to discuss it with the
follicular carcinoma in histological report. So how would you go ahead?
I have to discuss with the multidisciplinary team, and then I'll have to work her up for total or hemithyroidectomy.
Yes, but before that, you'll discuss it with MDT.
Yes, ma'am, with the MDT.
Okay, how would you differentiate between follicular carcinoma and follicular adenoma?
Yes, follicular adenoma. Yes, follicular carcinoma, it's actually invasive cancer, where it invades the capsule and the surrounding vessels. And usually they are differentiated, they cannot be differentiated on FNAC, so we have to do biopsy for histopathological examination. Ma'am.
Cytology, yes, biopsy. All right, good, thank you. Right, what I was saying that I think did you ask the patient to cross the arms and stand up? Because if patient fails to do that, then that shows the wasting.
Yes, ma'am, I checked that for proximal myopathy.
Okay, proximal myopathy. Okay, I'm sorry, I didn't hear. Yes.
I missed the lymphadenopathy, ma'am.
Yes, completely. And then yes, doctor has raised hand. Yes, please.
Can I add something?
Yes, please.
The first, when we examining the hand, so we should look for moisture hand, if the hands are sweaty or not. That thing should be noted.
Yes.
In hyperthyroidism, the patient are sweaty. Apart from that, on inspection, we should also check for Pemberton sign. So the Pemberton sign is to check the retrosternal goiter. The patient is asked to elevate both hands in above straight for a minute, and we see the congestion of the head and neck if there is thoracic outlet obstruction.
Mm-hmm.
I was just adding these two.
Yes. And even to see the tremors, what is the protocol? How would you do it? So like in exam, you should know you're doing it correct. Yes, Dr. Abbas.
Yes, ma'am. Thank you very much, ma'am, for allowing me to contribute. I just wanted to, I would answer your question and then I would make a few contributions on his examination. For the checking for flapping tremor or hysteresis in patients with thyroid toxic goiter, I think what's done is that you tell the patient to fan out his fingers and stretch them, keep an outstretched arms, and then you put a piece of paper over that, and then you squat at eye level. You check if the there'll be flappy using the papers that you've placed on both hands, outstretched hands. And if you notice that there's continuous flapping, that indicates that there is hysteresis, and that's possibility of patient having a toxic goiter. My contribution to your presentation, yes, you were able to touch most of the to the back. You went like twice. It will make your examination a bit clumsy, and then your examiner may mark you down. This is coming from somebody who is going back, so I think you should maybe try, and what you should do is that you should have some of the components of the questions, some of the components of the examination. There are some you do in front, and there are some you do behind, and then you now come back to the front to do the last set. So you start from the front. What you're going to do in front first is to inspect. So all the things you want to look for on inspection, you want to look for whether there's even a swelling again first. Then when the patient swallows, you tell the patient to swallow, and then you tell the patient to protrude his tongue. So, and this must also come out in your summary, because in your summary, you didn't say that the swelling comes out, the swelling, it moves on swallowing, but doesn't move on tongue protrusion. Immediately you say that you ruled out the thyroglossal cyst, which is a close differential of a thyroid swelling. Then the other thing, after doing all those inspection things, you would then check for, as you did, differential warmth from the front. So check for differential warmth, you check for tenderness. After that, you now go for you assess for tracheal deviation. You don't go to the back, or then you now come back to the front again to assess for tracheal deviation. After you check for temperature, tenderness, exactly, then you check for surface of the thyroid swelling. Check for the surface to see if it is diffuse, if it's not nodular or nodular. So you check whether it's a nodular swelling or it's not a nodular swelling, or it's multinodular if it has several nodules. Then you now check whether there is tracheal deviation or not. That's from the front. After you've done that, then you now percuss you now tell the patient to extend the neck. You demonstrate to the examiner that you can go below the thyroid mass by putting your 2 fingers below the thyroid mass if you can get below it. If you can't get below it, then you now percuss for retrosternal extension. After that, then you now go to the back. And you get to the back, what you want to first assess is to pinch the skin over the thyroid swelling in 2 planes to assess for fixicity to the skin. Then you now hold the thyroid mass and then move the thyroid mass to check whether it is mobile. Then you now tell the patient to tense his chin on your hand to see you. Then immediately you tell him to tense the chin on your hand. You palpate the sternocleidomastoid muscle to display to the examiner that the sternocleidomastoid muscle is tense at this point, is in action. Then you now palpate for, you now move it on that side. You move the lobe on that side to show the examiner that it is not attached to the sternocleidomastoid muscle, neither is it attached to the other structures, to the carotid sheath. Then you also do the same thing on the other side. Then you now palpate for the carotid pulse. Then after you've palpated for the carotid pulse, before you palpate for carotid pulse, what you want to do is to check for lymph nodes enlargement. Then you palpate for carotid pulse, and then you now use your stethoscope to listen for the carotid breathe. After you're done with that, then you now put your hand to, if it's a female patient, before you even start the examination, you'd have told the patient, if the patient is wearing any headgear, to remove the headgear. And then you would now tell the patient, sorry, I would like to run my hand across your hair now. What you want to do there is to check for scalp metastasis. So you run your hand across the hair of the patient to check for scalp metastasis. When you're done with that, then you now palpate also the spine of the patient, because the patient may also have spine metastasis. You now do your Navziga sign. That means you want to check for, before you go to now, you want to check for proptosis. So you squat behind the patient and move the patient's head and head back in a way that the upper orbital rim is going to be in the same line with the lower orbital rim to check for proptosis. After you're done with that, then you now come to the front of the patient and then do your lead lag and lead retraction and then check for the ocular movements. When you're done with that, you now check for asterixis. You now do your, after you're done with asterixis, at this point, you can either tell the patient to shrug his shoulders. After you're done with the hands, you can go to the shoulder and tell him to shrug the shoulder against resistance. That's, you're checking for proximal myopathy. Then you now check for ankle, you check the palms to see if they are sweaty and look for finger clubbing. And then you now go to the shin to check for pretibial myxedema. You do the deep tendon reflex. You can just do only the knee jerk, and then after that you tell the patient to stand with his arms across his chest to see if he can do that without support. That would also rule out proximal myopathy at the hip. The first one you did was at the shoulder. So if you're done with this, you're done with your examination. You thank the patient, then you summarize to the examiner, and then you wash your hand, and you thank the patient, you wash your hand, you summarize to the examiner, and then you'll wait for your question. You give your differential diagnosis and wait for the follow-up questions. Thank you.
Good, thank you. I'm not sure about the rubbing hand in the head and checking for the spine. This is something for thyroid examination, we can't go that far. Time isn't there. But Dr. Santosh raised hand. He wanted to add something. Yes?
No, ma'am. Actually, yeah, someone cleared it actually regarding that tremors. Yeah.
Yes, right. Thank you so much. Good, thank you. Amar, and here is the question.